Welcome back, Focus Learners, to Decode Healthcare with Harshal. Quick reminder right off the bat, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Okay, let's jump right in. Today, we're setting up a really powerful analogy. I like to call it the engine and fuel concept. We're going to use this to completely demystify how clinical documentation actually translates into hospital reimbursement. We're essentially popping the hood of the inpatient perspective payment system to see exactly how the specific words of physician rights turn into the hard data that literally sustains a hospital's financial lifeblood.
So let's start things off with a massive, macro-level question. How exactly are hospitals reimbursed for complex patient care? I mean, really think about it. You've got thousands of patients, right? Each one has totally unique physiologies, and they all respond differently to treatments. So paying fairly for these highly variable hospital stays, that requires an incredibly logical, highly structured system. You obviously can't just guess the cost of an admission. You absolutely need a standardized metric.
Okay, let's dive right into this. At the very center of it all is the DRG, which stands for Diagnosis-Related Group. This actually originated way back in the 1980s at Yale University. Simply put, it's a statistical system used to classify any inpatient stay into groups that are expected to have similar clinical characteristics and resource consumption. In short, clinical similarity plus resource similarity equals one uniform payment group. It's kind of brilliant. The DRG system takes thousands upon thousands of possible diagnoses and procedure combinations and elegantly groups them into roughly 750 distinct payment categories.
Here is our quick roadmap for today's lesson. We'll start with decoding the MS-DRG system, then move to the anatomy of the grouper, followed by the power of CC and MCCs. After that, we'll hit clinical documentation improvement, or CDI. And finally, we'll wrap up with a masterclass on sequencing sepsis.
Section 1. Decoding the MS-DRG system. Let's get into it. This system has evolved a ton over the years. We started out with the original Yale DRG, which really just grouped things largely by the principal diagnosis alone. Then we saw broader systems pop up, like the IPDRG, which added some much-needed pediatric and obstetric refinements, and the IPDRG, used by Medicaid to add a 4-level severity scale. But the real game changer? That arrived in fiscal year 2008 with the Medicare Severity DRG, or MS-DRG. The entire system shifted away from just basic principal diagnosis grouping to this modern MS-DRG model, which critically differentiates cases by severity and comorbidity.
Moving right along to Section 2, Anatomy of the Grouper.
Think of the grouper as a highly systematic engine. It assigns a category in 3 very logical steps. Step 1 is identifying the major diagnostic category, or MDC. There are exactly 25 of these, and this step essentially checks for the primary organ system involved, like the circulatory or respiratory system. Step 2 is determining the medical versus surgical partition. Here the engine is just verifying if a major operating room procedure actually occurred. If yes, boom, it goes down the surgical path. If no, it takes the medical path. Finally, Step 3, apply severity adjustments. This is where the engine scans for those all-important CC or MCC codes to determine the final payment tier.
Which brings us perfectly to Section 3, the power of CC and MCCs.
Now, what's really interesting here is how we define complications and comorbidities, our CCs, and major CCs, our MCCs. Basically, these are secondary conditions that either coexist at the time of admission or develop later on. They increase the severity of illness, they demand complex treatment, and they extend the patient's length of stay. Think of them as massive multipliers that can drastically shift the base relative weight of a hospital stay. Literally, just a single MCC can transform a baseline payment into a substantially higher reimbursement tier. And that's absolutely crucial, because it accurately reflects the true cost of caring for that critically ill patient.
Just look at this stark contrast to really grasp the financial reality here. On one side, you've got poor, vague documentation. It just says pneumonia and type 2 diabetes. But on the other side, we have highly specific documentation, sepsis, and type 2 diabetes with ketoacidosis. That level of precision instantly triggers an MCC. Going from a simple, unspecified description to an exceptionally specific one can literally double the hospital's financial reimbursement for the exact same patient encounter. Why? Because the engine finally has the high-octane fuel it needs to output the correct relative weight. It's a real game changer.
All right, Section 4. Clinical Documentation Improvement, better known as CDI.
So there are quite a few real-world triggers that actually require a clinical coder or a CDI specialist to formally query a physician.
Some really common ones are incomplete diagnoses, like just writing infection without ever specifying the actual organism. Then you have conflicting notes. Maybe one physician writes UTI, but another note clearly says pyelonephritis. Or maybe the documentation is just completely ambiguous, saying something like possible pneumonia with zero clinical validation. Whenever the documentation is inconsistent with the lab findings, the CDI specialist, think of them as our vital mechanic, has to step in and clarify the record.
Now, it is absolutely crucial to understand that there are incredibly strict compliance rules governing these queries, which are overseen by organizations like AHIMA and ACDS. The rule goes like this. The query must present all clinically reasonable and supported options based on the available documentation, including the option that results in no change. We really have to emphasize this compliance rule. The mechanics of coding must never, ever lead a physician to a specific, financially motivated answer. Never. It always has to be about capturing the objective clinical truth.
Let's move into our final section, Section 5, a masterclass on sequencing sepsis.
And this brilliantly illustrates how the sequencing priority rules work. They dictate that the principal diagnosis drives the entire major diagnostic category, while your secondary codes determine the CC or MCC status. So for a high-stakes condition like sepsis, if it's present on admission and it is the primary reason for the stay, that systemic infection code takes the driver's seat as the principal diagnosis. It essentially pulls the whole admission into a specific, highly weighted infectious disease MDC.
So the crucial point here is really following these strict procedural steps so you don't get cognitive overload. Step 1. Identify the specific underlying infection. For example, sepsis due to E. coli. Step 2. Check the documentation for severe sepsis or septic shock. Step 3. Identify any acute organ dysfunction, things like acute kidney failure or acute respiratory failure. And finally, Step 4. Apply your principal versus secondary coding rules based on what was actually present on admission. If you follow these exact steps, you are ensuring completely accurate, audit-proof coding every single time.
Let's move to a concrete case study and see exactly how this builds. Take a complex diagnosis like septic shock due to pneumonia. The exact codes generated by precise clinical tracking are J18.9 for the pneumonia, which is linked with A41.9 for sepsis, and then crucially, R65.21 to capture that severe sepsis with septic shock. Notice how this layered sequencing perfectly tells the entire clinical story. You have the etiology, the systemic response, and ultimately the severe manifestation. It's like a giant puzzle coming together.
I'm going to leave you with this provocative final thought. How can a single missing word in a medical chart alter the entire financial and statistical reality of a hospital stay? As we've clearly seen today, simply missing a phrase like with ketoacidosis or septic shock can drastically downgrade a hospital's rightful reimbursement and, worse, completely misrepresent the patient's true severity of illness. So keep learning, keep analyzing, and always remember the incredible stakes behind every single word of clinical documentation. Now, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Thanks for tuning in, and I'll catch you in the next one.